The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Thank you very much for the introduction, and it's a great pleasure and honour to be here, so thank you for the invitation. As you've just heard, it has been my great pleasure to be in Orange for the last at least 7 years. I've actually been there over the last 10 years, and I'm extremely passionate about how to make this work. My focus is a systems approach, and so the case examples are very interesting, but really I just want to fix the whole system. I'll let you know how that's gone. This is a slide that you'd all have seen before. In my youth, we waited till the patient actually died and someone actually noticed, and then we sent the entire hospital there to see if they could save their life. And we've got now, since, on the back of the Garling report, this idea of the slippery slope and the early response to the Met team, the yellow reviews came out. And the recommendation was that this Between the Flags program would be implemented across the whole state. That's the whole state. And there's a big lump there in the middle, which is Western New South Wales LHD, which is where I work. So the reality of rolling out a Between the Flags program is just a little bit different, and it is impossible to take a metropolitan template and simply lump it on top of Western New South Wales. Just a bit more about our district there. It's got 37 sites, free base hospitals, 4 procedural sites, and 31 small sites which are variably staffed and variably resourced. Some up to 10 at a time will not have a doctor there. All have a Red Cross on the door, of course. Western New South Wales is similar in size to Britain. It's got 3 major centres there down in the bottom right-hand corner, 40,000 each in Dubbo, Orange and Bathurst, and then totalling about 250,000 in the district. And if we just compare that to somewhere the same size, it's obvious and apparent how sort of sparse our population is, and that has its own challenges, and we can't cry about that. We just get round them. The challenge gets bigger, though, because Western New South Wales are a large population. We certainly up there with some of the more obese in the state. They're enthusiastic quad bike riders, horse riders, a lot of trauma. We have a high Indigenous population, and even once we do come to transporting people, the distances can be affected by things like snow and wind and kangaroos and weather. So it's not easy. An early inroad into how we would manage this problem was the Critical Care Advisory Service. This was launched by my predecessor, John Lambert, obviously before his time. On the right there you'll see is a Sony security camera. One of those has been installed above the emergency bed in every single small site in our district. And this is the web portal that I go to when I'm called to advise. The way it works is that if you as a clinician in a small site feel concerned, then you call a centralised number, and that will come through to either an emergency or intensive care doctor who will take the call with the assistance of this camera. When I first heard about that, I thought, it's ridiculous. I've got brilliant English and I don't need a camera. That won't add a thing. I've taken that all back. The camera adds a lot, just partly in terms of just seeing what things look like, how panicked people actually are. You can confirm observations, confirm orders, and you can be an excellent team leader with this camera because you cannot go there, so you can only give instructions. However, the Between the Flags program sort of mandates that when the patient goes into the yellow or red zone, somebody will be called. And the problem we have with the Critical Care Advisory Service is that that's a call if you want to thing. It's not you have to call. And as soon as you sort of go into this territory, which you will all have encountered perhaps in a metropolitan centre, is how do you make people call? The dots in the red, what do you have to do to get them to call? So that's only one of the challenges, and I just made a list of the first 20 things I could think of. What are the challenges? And there's more, there's 120. That's all been quite nicely packaged in this Wheel of Fortune on the CEC website, and that really does cover a lot of the major areas. But the problem is, of course, again, just applying that to a rural location. I wrote in my piece there in the booklet that it was a tantalising challenge to try and address this problem in Western New South Wales. This is Tantalus, who was so naughty that he was consigned to Tartarus, which is the deepest and possibly furthest west part of the underworld. And he, every time he went for one of these fruits, it just bobs up out of his reach. And every time he goes for a drink, the water recedes. And this is often how it feels when trying to address a problem in health, is it's just always out of reach. There are some very straightforward recommendations. It's the implementation which is always the problem. So maybe the literature could help. And so I've gone with Cotter's 8 steps, and the first step is increase urgency. We have a strategic health plan in Western, which tells us to improve the health of our patients, which also has instructions around better quality of life, care closer to home, more dignified death, and uncompromising adherence to standards. So some standards that we mustn't compromise between the flags, and then the accreditation standards, of course, which are very comprehensive, and we have struggled to meet accreditation in a number of our small sites. So these are levers and tools that can be used. Perhaps a louder message is our transport bill. $26 million is spent every year in Western New South Wales moving patients around. That's a lot. And just an interesting fact, which is in our strategic plan, the staff travel the equivalent of, it's about 40,000 kilometres per day. That's taking blood tests and this and that and goodness knows what else, which is equivalent to driving around the world once a day. We need a virtual solution to our problems. So the patient flow unit, where I am now lucky to work, has understood that they have quite a central role, that they are at the hub already of a network, and perhaps we could expand that role to help to build a plan. So we wrote that on the back of an envelope like this one, and it became apparent that getting world-class rural healthcare wasn't going to be so easy. I got a friend with good computer skills to draw it up for me like this, and it's like everything good, it's got 3 pillars. There's 3 sort of things. We thought we could have something measurable, optimising transfers, something a bit aspirational, zero harm, and then postcode equality, which is actually something that everyone deserves. In terms of optimising transfers, there is a whole piece to this around advice, avoiding transfers that we don't need to do, building capacity in small sites so that more patients can stay there rather than always moving, and perhaps having distinct clinical pathways designed for the country. In terms of zero harm, this requires early escalation. The Met response, not the Met team, because there just isn't one necessarily out there. Minimising variation. This makes it easier to educate because we're just singing from one song sheet. We can standardise equipment, we can standardise policy and drug protocols, all of which sounds easy but is really very hard to negotiate. And then postcode equality. This is also aspirational, but actually is what it's kind of a human right. And so we can't just stop and say, oh, it's a bit difficult there in the country. And this equality has to expand beyond critically ill and acutely unwell patients into the chronic space. The enablers are, as you would expect, executive buy-in. We need logistics, we need technology, we need strong governance. But I'm going to also put it out there that we really need the public on our team. I've come to understand that when negotiating or lobbying or asking for things and resources, that you can present data, and it talks a little bit, but it doesn't talk as loudly as the public going to their MP and saying, this is what I need. So it is my hypothesis, and I'm yet to test this fully, but that a mass media campaign to explain to the patients what they deserve, and then they can go and ask the politician, and then we will have a little bit more backup, I suppose. Equally, the public need to understand that their local hospital, to which they are deeply emotionally attached and very possessively, but this is their hospital. Sometimes there's not enough behind the door of what they may need in an emergency. So it is our mission to put behind that door a centralised telehealth support system. This is one of our unsuspecting emergency department doctors who is now a patient flow doctor. This is him in his office where we run a support service to all the rural sites. We can see them electronically. As of last year, we are all on EMR now, so all sites have got the computer, not the NBN, but they do all have a computer, and we can see their observations. I'm looking forward to e-meds in this particular setting because we will then be able to electronically prescribe and have visibility around prescribing, antimicrobial stewardship, things like that. But we want to, one of the important things about this telehealth service is that it is delivered by senior people, by a consultant. I think it needs trust, so the public and the local GPs need to trust the person that they're talking to, so this is not a job for the juniors just yet. There's a few things to help Colin there in his work. This is Wally, as you've never seen him before. Wally has two-way camera, two-way speech, and has a camera which the telehealth doctor can control remotely. Wally can do lots of things. He can do consultations, he can do medication reconciliation with the pharmacist, he can give chemotherapy as the second nurse, he can advise on dialysis, so Wally's got a lot of gifts. He can run to Met calls, and certainly we have also used him, because of the two-way component to the communication, we can have quite sensitive conversations with patients and their families. Not everything can be done through technology, and this SARS Assist, which has already been mentioned, is a vital part of our sort of arms and legs. The local staff in regional, or certainly in Western New South Wales, are excellent. They're truly excellent. They're very brave. They're very have a go. And I have seen amazing things done combining the local nursing force with the SARS Assist. So that is a vital part, a partnership for us with ambulance. In terms of trying to fund this, it's really hard to demonstrate the value of early antibiotics. We know it's the right thing to do, but it's very hard to demonstrate. We know the value. It's very hard. We know that presenting late to an intensive care unit, for example, could mean you spend a lot longer on a ventilator, a lot longer in rehab, a lot longer with delirium. But putting a price on that is very hard, so therefore building the business case is very difficult. This is a very simple database that we've recently put together to just simply say, if the medical officer in patient flow gave advice which avoided a transfer, we document the cost of that transfer. This is the month of July, where nominally we saved $107,000. This is quite simplistic, but please don't tell my executive, because this has funded the patient flow doctor. I do believe that the conversation, where possible, has to centre around quality. This is Lightning Ridge ambulance station. If the Lightning Ridge ambulance is sent out, it can't go anywhere else for quite a while. So this is one consideration that we have. Quality has to be the centre of the conversation, and if there are best practice standards from the ACI, CEC, I don't see why we shouldn't be meeting them both in the metropolitan, regional and rural centres. Certainly in our base hospitals, 30% of Met calls end up in end-of-life discussions. And in a rural setting, what tends to happen is everyone freaks out, oh my goodness, they're really sick, get them a plane, then they fly somewhere and die very far away from home. And this is particularly problematic for Indigenous population, but really is quite wasteful of a lot of, apart from the quality problem, is quite expensive thing. So with a bit of experience, sensitivity, a Wally, whatever it takes, and some change in culture where we understand that some patients don't have to move, not everyone has to travel. This is a quote which has been attributed to Abraham Lincoln. It's around, this is the first time I've spoken in this kind of forum about what is obviously a passion for me, but it is easy when one feels passionate and correct and sure to be a little bit of a zealot, and I can see exactly where we need to go, but I have to say, perhaps it's better sometimes to take a diagonal route, not necessarily bore through the mountain. There is a lot of political, parochial, threat to autonomy, reasons why it is difficult to implement this kind of confronting change. And it just takes time and patience and some setbacks. be ready. It is clear to, well, I think it's clear that at the moment we don't have a training program for virtual medicine. There are different risks involved in virtual health, and they have to be learnt and understood and appreciated. And at the moment, nobody grows up saying, I just want to be a patient flow doctor. I've never heard that. So I think there has to be some kind of training program to train people in the pitfalls, the skills, the communication skills, the triage of virtual medicine. I'm looking forward to the college, which I think will be with us in the next 5 to 10 years. And perhaps Western New South Wales will be delivering health like this in the future. And obviously by then we'll know about metcalls before they happen. And you're all very welcome to come help me.